Steve, I want to thank you for that passionate talk on the future vision for home health. And we have about 6 or 7 minutes for questions or comments if anyone has. Seeing no one at the mic, I'll take the chair's prerogative. So I think Amy Berman, at some point this morning, I can't exactly remember when, talked about the notion of the importance of defining home health. I think on the previous panel, I think Barbara was talking about, suggested we look at the Australian experience, and I think they have probably a bit more, less focus on a purely medical model. A lot of European systems have a much less focus on a purely medical model and think about the linking of the social to that. The model that you were promoting seemed to have a more medical focus, and I just wanted to know if you feel that there's a disconnect there, or is this part of the label issue, or are you thinking about this in that way as well?
Yeah, I think that I believe if we're talking about the Medicare program, I think the Medicare program is about medical services. It's not a long-term care system, and I personally wouldn't advocate for it to become one. But I think that Medicare home care services, the breadth of them, home health agency, home medical care, new models in the Medicare program, independence at home, that they enable long-term care, right? If people are going to age in place at home with long-term care services and supports, as their medical condition declines, they have exacerbation, deterioration, or to try and prevent that, they need primary medical care services, and they need the escalation of other types of services at home. So I believe that the role for Medicare is and should be the support of primary medical care needs, and also the ability to escalate health services needs at home so that people can age in place, so that caregivers like the ones that we met today and waiver programs and other models of long-term care at home can be successful. There needs to be a medical component to that, and I think that that's what the Medicare program provides for, potentially.
Excellent.
Thank you, Steve, for that very thoughtful presentation and that construct. I was looking at your 4 main ingredients, and I was just wondering, I know that they say that success is built when the patients stop thinking of themselves as passive patients and begin to think of themselves more as active healthcare consumers. Talk to us a little bit about the role of the patient in these 4 major ingredients. Is it woven throughout? Is it another ingredient?
Well, I think what I embraced as the first main ingredient was medical care based on evidence-based geriatric medicine, palliative medicine, and rehabilitation medicine assessment concepts. And one of the common themes between those models of assessment and care planning is a patient-centered approach that takes a holistic look of the person. They're informed by Engel's biopsychosocial model, in fact, of function, physical function, psychological function. I do think, though, that one of the things that we have to come to grips with is that, and maybe this is going to come across as overly paternalistic, is that for the populations that I think benefit the most from home care, they are quite dependent. I mean, we're talking about cognitive impairment and ADL impairment, and I think that there is some degree in this population in healthcare of fairly structured and strong interventions if they're targeted appropriately. But I don't know if I answered your question, but those are my thoughts at what you brought up.
Penny?
Yes, I'm Penny Feldman from the Research Center of the Visiting Nurse Service of New York, and it was a great and always inspiring to listen to you, Steve. We've heard this morning that home care agencies, as we know them, are now becoming more and more flexible. They're successfully inserting themselves or seeking to insert themselves in many of the different models that are evolving. We also heard from Barbara a sort of poignant statement, that home care agencies seem to remain the little fish in the sea of big fish. So, and I think many agencies are struggling about their core business and trying to figure out what they can do to prepare for the future given all of the different opportunities around them. So One of my questions for you is really what you perceive the one or two most important things are that home health organizations that want to survive and be flexible and be part of the home-centered system in 2014, what can those agencies really do? And in what ways can groups like the Alliance and Visiting Nurse Associations of America and so forth, how can they help prepare agencies that want to and should survive as vibrant agencies of the future? And then secondly, is there anything in the existing Medicare home health benefit or regulation that needs to happen on the other side to allow agencies to grow as vibrant, flexible organizations? So it's sort of, what should the industry be doing? And then is there anything on the regulatory or payment side that facilitates that flexibility but survival?
Thanks, Penny. You know, I think if you're talking about the one or two most important things that home health agencies can do, I think it's embrace the role of value creation. Sometimes our staff, and I've heard this throughout my experience in home care, will say, Landers, these hospitals don't know what they're doing. They send these patients home that are so sick. They've got all these needs. They're complicated. What were they thinking? And I've come to think to my colleagues, unfortunately, if this is your perspective, we're in trouble. That actually, this is the situation where you have the most opportunity to create value. And I know as a physician, I remember, I see my mentor and department chair, Dr. Kakano, here from when I was a resident. I remember when you'd go into the next room to see a patient, you'd hope it'd be a 30-year-old with a runny nose, right? Because everything else seems so complicated. But our value can't be on marginal services. Our value has to be through helping people in need where their health outcome and their cost outcome is going to be different if we hadn't been there. So I think taking an attitude of value, I think eliminating a culture, if it exists in any organizations, of comfort with manipulation. I've heard at various places people say, well, if we do an extra visit, we get paid more for it. Well, that's crap. We can't have that type of culture. So I think our organizations need to adopt a culture of value creation and a culture of accountability where it doesn't exist. And I also think that on a national level, that the type of exercise that we're working on today, if we can get any closer to embracing a vision for where home health agencies go in some type of collaborative fashion, that we can work on some of those policy things. There's nothing, I don't think, overnight. Obviously, it's not easy to get Congress to do anything if it requires congressional action, like the issue around nurse practitioner certification. But if we can at least in our small little boat in home care come up with a few broad aspects of a vision that we can agree on and together advocate for, I think maybe we'd get there further. But I think, and one other point is that this is necessarily different in different places. And if we try and put a cookie cutter perfectly on this, it's going to cause some problems. I was just meeting with a home health nurse practitioner who's also a primary care nurse practitioner, who's also a federally qualified rural health center nurse practitioner, who's also the transition and care nurse practitioner, and also the hospice nurse practitioner in West Kansas. And in the same week, I got to meet with people that were trying to figure out how to transition heart surgery patients back to New Jersey from NYU, even though their clinicians don't have licensure and certification in the state of New Jersey. And I know it's different in different places. So let's think about what are some of the broad themes and resources that can make an impact. What are the carrots and sticks that can make sure that we get closer to value rather than waste?
Steve, thanks so much. It was a great, great discussion. And thank you all for the questions, for all the questions this morning and for all the speakers this morning. And Tracy is going to give us some direction on where to get calories.
Thanks, everyone. I also want to recognize all the people watching on the webcast. I've been getting a lot of emails, and if you didn't hear it this morning, yes, we will be posting slides. We will be posting the individual videos of the speakers throughout this conference within the next couple weeks as soon as we can. For lunch, for those of you here, we have a cafeteria on the 3rd floor. There's a lot of you here, so it's going to take some time to go through that. There's not a whole lot very close walking distance, but you can certainly try to go over to 7th Street. Speakers and planning committee members, you have a meal ticket inside of your pocket. If you sign that, you don't have to wait in the cafeteria line. You can just hand it to the cashier, so that'll help speed up the process for everyone. And where you have a packed afternoon, so we're going to start just a little bit after 1 o'clock. So go ahead.